Screen?
Yep.
All right. So this was an interesting case. This patient was, referred to Sloan for metastatic disease of unknown primary. This was the salient PET from outside institution. You can see a bunch of little areas of hyper metabolic activity in the liver. Really can't see much in terms of on the low dose CT, but
Victoria, can you speak up or like hold the dictaphone close?
I'll hold it better.
Yes.
Okay. Should I repeat what I said or no?
You said multiple small foci of FDG avidity.
Right. And you can't really see anything on a low dose CT, which is not surprising. The arms are down. She's a chunky, she has some attenuating tissues in the subcu. So, so it's not shocking. Okay. So she was sent then to MR to assess, extent of disease. And again, they did not have the primary. And you can see I'm just showing the diffusion, and this is hepatobiliary phase, and you can see the extent of disease is fairly substantial. There was some lymphadenopathy right here in porta hepatis, and as we, and then here a little bit another lymphadenopathy, and we couldn't see any other disease in the abdomen. When we were scrolling through some findings, hold on. So here's our coronal. And we're just kind of going through. You can see the mats are fairly, as Aarti likes to say, evil gray of tumor. And as we were scrolling by, I noticed this thing in the gallbladder. So it's a kind of in a funny position, right? It's like in a fold, and I knew that the chances of getting it, catching this area on axial T2 was, it's just going to be volume averaging. So I was going to just say maybe this is a site of primary tumor, but then we caught it very well on axial T1. You can see right there. You can see it's an actual soft tissue mass with a little bit of kind of irregularity. So this is a primary gallbladder cancer. It's a little bit of unusual because it's relatively small tumor, and it didn't invade into the liver, but it did cause multiple liver mets. So we found the primary, and I guess the teaching point that I want to make here is importance of orthogonal planes, particularly for T2s. We sometimes see, studies from from outside institution, and they omit coronal, coronal anything. And this is just an example how this is very easy not to, to miss on the axial. Just give me 1 second. I'm gonna pull up the axial T2 so you can see what I'm talking about. Axial T2.
While you're pulling that up, I do have a couple of questions. One is, in retrospect, is there anything hot there on the PET?
No. So
oh, wow.
Here's a T2, right? And you can see that we just kind of like, there's no way to call this on T2 on the axial. And in terms of PET, I did not, I looked, again, let me pull it up. I'm going to move away because it unfortunately, it shows the, once I change the display, it may show sometimes. Here's the thing. You can see that even, I don't know, so I don't know, PET wise, I don't know why this is showing obviously many fewer tumors that the patient actually has, and granted, a lot of them are very small, so you can see here. So they're probably below the resolution of PET, so the bigger ones are coming up. So the
it could also be that they're poorly differentiated, and so they're not even taking up glucose, because if that small gallbladder cancer caused all those mets, it could be a poorly differentiated one.
Right.
And its PET would be limited.
You can see maybe this, it's just not, there's no nothing kind of really focal there. This looks like that. So I doubt this is correlated. So there's really no correlate there on PET. And you can see here again, like the best shot for us to see it was this axial axial pre-contrast T1. So because once we got to post-contrast, you can
We don't see your MRI.
there,
by the
there,
way. Okay.
there. You can see how here it's very easy to mess this up and not see it. But on the pre-contrast T1, you can see it very, very nicely. So again, just make sure your protocols do have at least one orthogonal plane for cases like this. Is also, sometimes we get this in urinary bladder when the tumor just sits right on top, and you may not be able to see it in the axial plane. It will be just kind of, it's hard to see, but on orthogonal planes, you'll see it nicely.
And I have a question for you about your hepatobiliary phase. I know you are now at a new institution. Are you guys using hepatobiliary agents for HCC screening, and or what are you using it for? Like for
so Sloan does not do screening, right? It's a cancer center, so we don't, we get fairly advanced cases. So we do use it for metastatic workup, or like any either suspected or definite metastases, we'll use it. And then for HCC, usually HCC, the cases that I've seen so far that get referred to here are fairly advanced, because it's not a transplant center. So, those are patients who are not eligible for transplant, usually quite an advanced stage.
Got it.
So
this month for our journal club, we're actually reviewing a recent AJR article that was a prospective trial out of China, comparing, extracellular agent versus hepatobiliary agent for HCC screening. And they concluded that the extracellular agent was better, but I have not yet read it. So I'm going to read that and come back to you.
Okay.
Because I know you
I think I know what you're talking about. That there were some.
Yeah, it's a recent one that Melina picked
Yeah.
for our journal club. So,
okay. And then let me get the other one. Hold on. Patient. So this was a study performed at the outside institution. Patient was an ED case, and they appropriately picked up this fullness right here. And patient was referred to abdominal MRI for workup. Again, this is from outside, so I don't know why they went straight for MRI, but that's what they did. So let's extend this. So you can see, I'm just showing select images, T2 and T1. You can see a well-defined mass here, very heterogeneous on T2. Oh, you can see here. So at this point, the patient was told that patient has pancreatic cancer.
Victoria, one thing I'm thinking about with those cystic spaces is a periganglioma, because I know they can have cystic spaces.
Right. So wait, hold on a second. Before we give the differential diagnosis, here's the post-GAD.
Oh, I see. They're not cystic.
Right.
Was it like they weren't bright, right?
Right. So, okay. So that was it. It was still right. Like, okay. So I don't have the report. So I don't know exactly what was that, but the patient was told the patient has pancreatic cancer. Patient had repeat CT about 6 days following the MR. Again, I'm this is just a story, and this is the mass. This was described as necrotic pancreatic mass, and patient was sent for CUS. CUS was non-diagnostic. At this point, patient was told that she has probably inoperable pancreatic cancer, and she came to us, and here it is in our show phase. And so the pancreatic biliary surgeon called us and asked, could you just please look at the images. So what do you think?
The pancreas looks okay. Like there's no ductal dilation. Parenchyma is fine. It might be, can I see that in a coronal?
The CT?
CT or MR, like I want to see if it's arising from the pancreas.
Okay, hold on. Archie, just in case, can you pause the recording for a second?
Okay, go ahead.
Okay, so you can see here, that's the lesion.
Briefly, when you showed that enhancement, I thought like, could it be a partially thrombosed pseudoaneurysm, but I didn't see flavoids on the T2.
So this is what I thought. I said, you know, honestly, I don't think this is arising from pancreas. And given this, like these T2 hyperintense foci, and given that these areas like hyperenhance fairly avidly and enhance, I said, you know, I think this is some sort of, you know, hematoma associated with pseudoaneurysm. And if you look at subsequent, so CT was done subsequently, you can see that there's really these foci of enhancement are no longer seen. That there was no pre-contrast on this one. So I said, you know, honestly, I think this is some sort of pseudoaneurysm, you know, with, you know, probably was partially thrombosed in the MAR by the time CT was done, you know, it's already thrombosed. They were like, well, you know, why would the patient, she has no trauma, like, why would she develop pseudoaneurysm? I don't know, but anyway, so then I said, well, can you know, please review the CUS sample. You know, is it possible that the CUS sample is consistent with, you know, coagulated blood? And when they went back and looked at it, indeed, it said something about like blood products, but that wasn't very convincing, right? Because you know, like if they could have gotten some blood products from just based on biopsy. Anyway, so but they decided to go along, and they send the patient for IR for an angio, and indeed this was a pseudoaneurysm arising from GDA, and they embolized, and the patient's, hold on, let me stop sharing again for example, or if you want, you can see patient, the celiac was embolized, and you can see that the mass is getting smaller. So indeed, this was like partially thrombosed aneurysm. So this was, you know, happy ending for the patient. She was, you know, obviously went from, you know, you have very limited life span left to we cured you. So she was happy.
Cool. I've seen a few of these now. I think it's interesting. Like we definitely have to think about that and bring it up, because if they're going for biopsy, you don't really want to biopsy a pseudoaneurysm. Luckily, it sounds like that EOS FNA didn't, you know, it was already thrombosed or they didn't hit it. And then secondly, I have seen these, like you're saying, they were just spontaneous, and people like, they didn't have pancreatitis. Like, why did they get this hematoma in this area? And I feel like I've gotten the impression that like the GDA is just kind of a brittle vessel that can pseudoaneurize, like if you have pancreatitis, but sometimes even just spontaneously. So it sounds like in your case, it might have vasculitis, but I've seen just completely spontaneous ones too.
Yep.
Cool. Okay. Maria, do you want to know?
All right, so this is a young woman. She's 31, and she was getting this MR because she has history of prior endometriosis, and she had an endometrioma removed from her left ovary a few years back, and now she is having like pelvic pain and pressure, so they were worried about deep infiltrative endometriosis. So I'm starting with a sagittal, and she does have some findings of deep infiltrative endometriosis. There's a spot here between the bladder and the anterior lower uterine segment. There's probably some thickening here, posterior to the cervix here, and she had like some thickening of her ligaments too. But what really caught the radiologist who was reading this eye was this T1 hyperintense lesion in the right ovary. It's very homogeneously T1 hyperintense. And, you know, knee-jerk response when you look at T1 hyperintense lesion, you think of an endometrioma in your mind. And then this is the T2 correlate here. And this is the post-contrast I'm showing you of the same lesion. So I'm withholding some history, so feel free to ask questions about the patient's history.
Maria, I've seen this case because Nelly presented it here before.
Oh, really?
A couple weeks ago. But so I'm not going to say anything. But
Okay.
what? Anyone else? It's a beautiful case. It's a
I know.
great example.
Is it a torsed ovary?
Why do you think that?
Oh, because of the hemorrhage.
Why isn't this like an endometrioma? I'm like,
All those big follicles, right?
yeah. So that's what the catch of this case is, that this patient had hormonal stimulation from because she was trying to get pregnant from IVF, and these are all like enlarged follicles in the right ovary, and they're very dysmorphic looking. They're not like your nice robust looking follicles, even with hyperstimulation. And the catch that makes it a case of ovarian torsion is that these follicles, they do not enhance. Follicles should have nice enhancement on post-contrast images because they have blood flow to them. So all of these are dead. Even though on imaging, it's really hard to make a diagnosis of like to see like a torsed pedicle or like, you know, the whirlpool sign. I tried my best looking for it, but I couldn't. Maybe like it's like hiding in this spot here where everything seems to be like converged, like right at here. But on imaging, you can't really make out the whirlpool sign. So yeah, the T2 appearance is what gives away that this is probably a case of ovarian torsion. These kind of spoke wheel pattern appearance or pattern of ovarian follicles, because endometriomas, they should have like, you know, T2 shading, but not like discrete follicles in them. This is like too much a nice pattern for this to be an endometrioma. So yeah, but they took the patient about 3 days after this MRI to surgery, and it was like a torus necrotic right ovary. With hyperstimulation, it was like enlarged because increase in volume from hyperstimulation predisposes these ovaries to torus.
Very cool case.
Yeah.
Scary because a lot of people do undergo IVF and stimulation. Okay, awesome. Thank you.
Yeah.
Okay, this is my first case. Is a young patient, young male patient, and was having right lower extremity swelling. So what do you guys see or think?
Some kind of lymphoma.
Okay, so you're seeing a pelvic sidewall mass. It's kind of blobby and homogeneous. I'm assuming that's why you're thinking about lymphoma. It looks like it could be like a huge nodal conglomerate, and it looks pretty homogeneous. It's extending almost like through fascial planes because it's in the pelvic sidewall, but also going down into the ischioanal fossa down here. It was not lymphoma. I do have an MRI, but any other thoughts? Just like, you know, based on this, anything else in your differential?
Castleman, maybe?
Okay, good thought. So that can be unicentric, tends to be more avidly enhancing. Anything else? I'll show you the MR.
Aarti IgG4.
Okay, good thought. I haven't seen it so mass-like this, but anyway, this is now the MRI. Sorry, what?
Fibromatosis.
Fibromatosis, you said. Is that what you said? Okay, and why did you say that?
So this is classic for fibromatosis. Hypoid signal, infiltrating mass.
Yes. Good. Excellent. So this was actually desmoid-like fibromatosis. I'll show you on the post-contrast. It was a little heterogeneously enhancing. They tend to be more homogeneous. But this was actually a desmoid fibromatosis tumor. So we did, and so part of it was like more avidly enhancing. It was kind of heterogeneous. This part was less avidly enhancing. It was kind of different in different places. So I wanted to just make a couple of points about desmoid fibromatosis, but actually I want to show you a companion case. Let me just pause for a second. Okay, so this was a younger female, and this is a companion case, and we saw this kind of very homogeneous mesenteric mass. Couldn't exactly see where it was arising from. It looked separate from the pancreas, but because it was very homogeneous, we also brought up a desmoid, and we brought up a GIST tumor. Usually when they're this large, they're much more heterogeneous, might have central necrosis, calcification. And then this one was also resected, and this was a desmoid tumor. So, oh, and I'm going to show you the MR for this one. So this one on MR looks kind of a lot very different from the one I just showed you. It's not as T2 dark, like the other one was very, very T2 dark, like muscle. This one is actually kind of T2 bright. And then the mass itself is also very well circumscribed, as opposed to the other one that was infiltrative and crossing fascial planes. So I kind of wanted to show both of these. These are both actually from last week, or like the past couple of weeks. We have biopsy proof of both of them. And I think it makes a good point about desmoids, which is that they're just, they're variable. And I think these are kind of two very classic appearances for them. So desmoid is basically aggressive fibromatosis. When they're in the abdomen, people tend to call them desmoid tumors. They're associated with Gardner syndrome and FAP. They, about 80% of patients with FAP will get desmoid tumors. And they can have both, basically these two different kinds of patterns, either very well circumscribed or very infiltrative. And they can either be T2 bright if they're more cellular, or they're more T2 dark if they have more collagen. So don't exclude a desmoid if you're like, oh, this is too bright for a desmoid. They're supposed to be fibromatosis. It's supposed to be dark. They can be one or the other. And it doesn't necessarily even go with like which ones are well circumscribed or infiltrative. It goes with what is the underlying pathology. And then they used to do a lot of aggressive surgery for these, but they have a really high rate of recurrence. So if the patient is asymptomatic, they tend to do watchful waiting. If they have symptoms, they really don't want to do surgery. So they try to do anti-estrogen therapy. So they'll use tamoxifen or something called anastrozole. If that doesn't work, they can try Gleevec. And if that doesn't work, they can try chemo with doxorubicin. And also another thing they can do is proton radiation therapy. So just to tell you the follow-up for these cases, this one, the patient was having abdominal pain and really wanted this removed. So they removed it with negative margins. This came back desmoid. She does not have a history of FAP. And then the other one that I showed you, I'll just bring that one back up. This other one, you saw that it was basically, it's in a really tricky spot. It was in the pelvis. It was, it's actually obliterating. So this big enhancing mass here, it's obliterating the external iliac vein and encasing the external iliac artery. It was inseparable. It was abutting, the prostate, the rectum. So this, they decided was going to be a much more morbid surgery, was not worth it for this, benign tumor. Some of these spontaneously regress or remain stable. And so for this patient, they're going to give them anti-estrogen therapy and hope that it shrinks away, doesn't grow, and cause more kind of local mass effect. I seem to be having an issue with presenting this. So anyway, any questions about that?
So this was a interesting case. So you can see this is a woman in I forget, like middle age, around middle age. Should I just walk through the findings, Nelly, or? I mean, why am I calling you Nelly? I'm so sorry.
No, it's fine. Nelly's here
I
now.
know who you are.
No, Nelly is here now.
I thought you were calling me specifically, Victoria.
I'm sorry. No, I keep calling. I keep calling Aarti Nelly. I don't know why.
That's fine. No, I think we should talk about it. So it looked like a super dilated bile duct and then super dilated ducts in the left lobe. And I'm wondering about like a IPNB or.
Right. So this is, a very probably the most extensive case I've seen. You can see the CT and MR were done within, I think like a month of each other. You could see just a really dilated mass-like dilatation, right, with debris and almost like frond-like appearance inside. And then here it is on pre and post, on GAD, you can see again, like these frond-like enhancements. And then interesting part on coronals, you can see right there. Let's see if I can tighten this up so it's clearly seen. There, you can see that one of the ducts here ruptured, and now you have this T2 hyperintense, very heterogeneous material collecting in a subhepatic space. Patient did have surgery, but because it was ruptured, patient now has something like this. And this is about a year after surgery. You can see that patient developed peritoneum. God, why can't I say it? Mucinous. Aarti, help me out.
Well, like pseudomyxoma peritoneae,
Yes,
which
thank
is
you.
now called DPAM or disseminated peritoneal adenomyocynosis.
Right. So you can see that.
Really? There's a new name for it?
There's always new name for stuff.
I think the main thing is to differentiate, it used to be called pseudomyxoma. It's now called DPAM, but the main thing is to differentiate this sort of acellular mucin, which is the low grade mucinous stuff, versus mucinous adenocarcinoma, where you might actually see solid stuff. It's mostly in the context of like appendiceal tumors, but it's kind of the analogous thing here.
Okay.
But I have questions. So the IPNB, did it have like invasive cancer in it, or was it?
So this was invasive on path.
And sorry, was there other differential on this, or did you guys just go IPNB? I don't know that I would just like call it IPNB without including other diffs.
Oh, so I don't know. I read the follow-up, so I don't know. So I'm sorry, I don't know.
I would say like highly suspicious for IPNB,
Yeah.
but Nelly, what else would you want to put in there? Just like introductal cholangio, or like what else are you thinking on that from the original MR where like you had all those super dilated ducts?
I mean, go ahead.
No, go ahead.
Yeah, I mean, if something along the cholangial spectrum. IPNB is, and it's no, I agree with the findings. It's just, I mean, I don't know that I would just give that as an isolated diff, right? And it could be intrahepatic cholangio. It could be.
It's so the one thing is like it's so filled with mucin that like cholangios usually don't like expand the ducts like that, or like a common bile duct.
And like this frond-like enhancement inside right here, I think this is probably the most extensive example that I've seen fairly, and this is not like a common appearance for intrahepatic cholangio. You can see that like look like this like
agree. I mean, it's beautiful.
Papillary
this is like your bookcase
example
of IPNB.
And then
we have trainees here, so I don't know if
you can see now like over time the pseudomyxoma is increasing, so this is probably, I mean, you can see that there's enhancing components there. So
so actually that's interesting, because I wouldn't call this pseudomyxoma or DPAM. This is actually mucinous adenocarcinoma, which is a very different thing than like our normal pseudomyxoma, which is more acellular mucin. This is an insane case.
Right.
This. Yeah.
All right. So
okay, and just one more thing. Anu had a good point in the chat. She said IPNBs cause both upstream and downstream ductal dilation, which is unique to an IPNB, which we wouldn't see probably with a cholangio. So that like diffuse dilation of the CBD is like the mucin filling it. So, okay.
Sorry, can you give like a 2-sentence summary? Because I have a first-year resident on call with us just to explain what an IPNB is.
Yes. So IPNB is intraductal papillary neoplasm of the bile duct. And they used to be called, there used to be cystic lesions of the liver that were called biliary cystadenomas. In 2010, the WHO reclassified them into MCN and IPNB. MCN is like the pancreatic equivalent of MCN, so it tends to have ovarian stroma, more dominant in females, but can be in males, more dominant in the left lobe, segment 4. But it tends to be a more round mass with a capsule, enhancing septa and solid components, if it has those. Whereas an IPNB is like IPMN, where you get dilation of the ducts with papillary frond-like structures in it, and different than IPMN of the liver, of the pancreas, like 50% will have mucin and 50% won't. So anyway, we bring it up when we see dilated bile ducts that appear to have papillary fronds that also might have a lot of fluid in them, like that look like they're expanded with mucin. And yeah, this was a case where you also had invasive cancer, but they don't always have invasive cancer.
There's like 70% risk of harboring carcinoma in IPNB,
I
right?
think IPNB of the liver has a higher risk, whereas
Yeah.
MCN of the liver actually has a lower risk of invasive cancer than a pancreatic MCN.
Awesome, thank you. Okay, so this patient came in with nausea, vomiting, and abdominal pain. And here's coronal. Anything from anyone?
I see a horseshoe kidney and I see a stomach filled with debris with, like, I don't know what's going on with the antrum of the stomach, that it looks a little thick.
Okay. Anything else? Let me give you.
The TI.
I'm sorry, what was it at?
Is there something in the terminal ileum?
Oh, TI. Okay.
Coronal, it looked bulky.
Why is she
Okay.
showing us lung windows? Is there free air? Wait, is that?
Oh, there are droplets.
Oh, there's air in the veins, like lateral to the stomach.
Yeah.
So is there gastric like pneumatosis of the stomach with like vein?
Yeah, so there's these bubbles of air here, right? And as Aarti mentioned, mesenteric, it's like sort of coursing along the mesenteric veins. You can see the serpiginous outline. But the underlying, there's no other kind of secondary signs of ischemia, pneumatosis. And then if you look at the chest wall, there's also air bubbles in the subcutaneous veins here. So this patient, so this is a patient who, any guesses as to possible explanations for this?
I mean, sometimes we see air in veins if they've been injecting like into veins, but these seem like to be random. Oh, yeah.
So yes, so this patient has SVC stenosis, severe SVC stenosis. So the air comes from what was administered through the IP contrast. And then you see all these prominent collaterals that have formed. So sometimes when there's too much air, we can see that layering in the heart. But in this case, because the patient has a central vein stenosis, it's refluxing into the superficial veins and into the mesenteric veins. So we have an angiogram that we did subsequently here. Right, so because of the SVC stenosis, there's just like the distribution of contrast. We don't normally see this this much in the IVC, but we're seeing all of these sequelae, and you can see there's huge collaterals that are formed to try to reroute the blood flow. And so this is benign. It's not pneumatosis. It's just administered air, that was in there. So it's just a fake out.
Cool. I'm not even sure I would have picked that up the first time. But it's a good, yeah, that's a good review of that the collaterals can go back in through all of these places. I was looking for a focal hepatic hotspot in the liver. I didn't see that. So I guess it's just going through these like
Yeah.
gastric
Sorry, there was a question about TI. What was the comment? Should I reshare that? Because I did, the TI didn't really impress me, but let me make sure that we cleared the TI. What was the comment about the TI? Okay, never mind. Maybe it was.
It just looks a little full. Maybe they were wondering if that was the abnormality.
Oh, gotcha. Yeah, no, I didn't. I thought the TI was fine.
Yeah. Okay, Victoria.
This is actually a companion case to what Nelly showed months ago, weeks ago. It's a real case. You can see patient has cirrhosis. Patient was referred to us. Person was referred to us for a lesion that was found, and Nelly, very similar to the case that you showed here. You can see that there is arterial phase hyperenhancement, but as I was scrolling up and down, it kind of still had that kind of rim-ish look. Although I wasn't sure, right? So I know that if you're not sure, rim versus non-rim, we're supposed to go with rim. But I was like, am I just being too, demanding of this tumor? Here it is on the portal venous phase. It kind of becomes more or less iso as it does here on the delayed phase. And we did have access to the prior MR. Give me 1 second, I'll show it to you. There you go. So this was the arterial phase. I mean the contrast images. So here you can see patient has cirrhosis, and here's the arterial phase. And here, right, the tumor looks mostly heterogeneous, but here it doesn't at all looks like it's a rim. And then as you go down, it becomes, kind of iso to the liver. It doesn't really wash out at any point. You can see that on the very delays, it kind of retains contrast. Very unusual tumor. But when I look at T2, you can see that on T2, it did have a very targetoid appearance, as it did on the diffusion. So at this point, I'm like, okay, there's convincing evidence that I'm not insane, at least not insane in this region. So then it should have been, so I said, okay, fine, we're going to call it LRM, right? Rim arterial phase enhancement, LRM, provided the differential diagnosis of atypical HCC, combined tumor, and cholangio, and patient went for biopsy, and it was combined tumor. So
Victoria, we debate about this all the time now at work, and about like, is this a rim? Or is it just like a little bit of central necrosis or whatever? But I have a question. It sounds like on one study you had rim, and then on the other study it was not really rim.
right.
And so you're saying like, if you have two studies and one of them look like rim, the rim trumps?
Targetoid always trumps non-targetoid. And again, because we want to really preserve the specificity of LR5 for HCC. So it's not an error. Let's say if this came back as HCC, it's not an error, and it's not a failure of LIRADS. It's fine. But a third of LRM observations are HCCs. So that's okay. But if we called this LR5 and then it came out and and this ended up being combined tumor, that's considered to be an error.
Okay. And then can you explain to me and everyone what, like the rim, my understanding is like, that's because cholangios have like more viable cells along the periphery and central fibrosis?
Correct. So classic cholangios will have very cellular periphery and very fibrous core in the center. So they will have this very classic rim-like enhancement in arterial phase, and generally over time the periphery will wash out, and the center of the lesion will retain contrast, particularly in very delays. So you will have this rim arterial phase hyperenhancement, peripheral washout, and delayed central hyperenhancement. On diffusion, because the periphery is more cellular, you will see again that pattern of increased signal peripherally and not centrally. And finally, for hepatobiliary phase, because the central core is fibrous and fibrous tissue picks up contrast, just because any contrast, not just EVIST, but because, so then you will have central core, which is slightly hyperintense to the periphery on hepatobiliary phase. So if you see this pattern on any of the sequences, that's it. You just need one of them. So I showed you the T2 and I said, oh, look, it has a T2 kind of also target-like appearance. So T2 target-like appearance is not yet part of LIRADS, although we do see it. We don't see it a lot, but when we do see it, it's kind of like a trigger. If we just saw T2 like this, probably, we can't technically say LRM. But this was just kind of another piece of information that this tumor is not like your typical, HCC situation.
Okay, and then on the flip side, I guess you're suggesting also that it's not that common that HCC will have central necrosis.
They can, but again, the idea is that we have very stringent criteria for LR5, very stringent criteria. So that's why the sensitivity, we have to keep the specificity at above 95%. We have to keep, we have to sacrifice sensitivity, which means that a bunch of HCCs will go into LRM category. It's just if you see a lesion, the idea is that if you see a lesion with this appearance, it's obviously it's malignancy. We just can't be we can't have over 95% certainty that it's HCC, and that's why it goes the other way. Make sense?
Yep, got it. Thank you.
Harrison, our first year resident, is on, and so when for him, combined tumor, that's hepatico-cholangio. And so it has both histology of HCC and cholangio. Another term that's used is biphenotypic subtype. And these are important to know because they're not candidates for a transplant, whereas HCCs are.
Right. Plus they have like somewhat different behavior in terms of outcomes and they, different treatments are offered in terms of immunotherapy and chemo. So yeah, it used to be very, very uncommon, but it sounds like we see it slightly more often now.
Okay, I have a case of history of ulcerative colitis. Came in with abdominal pain. No prior studies here. So there's, diffuse colon wall thickening of the descending colon and sigmoid and rectum. That's probably related to patients. You see, the question is about the uterine findings.
How old is the patient, and do they have a negative HCG?
The patient is late 40s, and HCG is pending.
I mean, it could just be
Was
related to their
pending.
menstrual cycle, but it almost looks like a gestational sac with a decidual reaction underneath it.
Yeah, so this what the HCG did come back positive, and so this was a new diagnosis of an IUP. I know we don't see IUP commonly on CT, if ever, but this is a great example. So the endometrium is here, right there. And that's the decidual reaction that Aarti was referring to. And this is the intrauterine pregnancy that was confirmed on subsequent ultrasound.
So wait, so they don't routinely check betas?
Well, I think we didn't wait for the labs to come back before we went with the, it was an ED patient.
Yeah, I
so
think we don't routinely check everybody. We ask them if they think they possibly could be pregnant.
Yeah,
And if people
it
say
was
no, then
unsuspected.
we don't check an HCG in everyone. I was wondering if you almost might see a tiny little fetal pole, like there was almost a little hyperdense thing right there, but I don't know, could be hallucinating.
Yeah, right there.
Needs an ultrasound.
Yeah, and an ultrasound was done, and it confirmed it. Let's see if I can share the ultrasound.
Nice. It's actually pretty far along. So we see like the yolk sac, the fetal pole. At that size, you probably can see a heart rate.
Yeah, it was 8 weeks
Nice.
by ultrasound.
And then this comes up like, what do we do about the fact that the patient got a scan in the first trimester, but probably it's okay. Did that come up for you guys, like the discussion?
I wasn't part of that discussion if that happened.
Okay. But I think that the dose for like a single phase CT through the pelvis should still be below. Does anyone know? Isn't like 50 milligrams like the cutoff? I think it should still be below, like, you know, it's really not an effective fetus, but I'll have to look that up. Okay, I have a quick one. Nelly, do you have others you want to share?
No, that's it for me.
And Victoria, did you have?
What was your question?
If Victoria has a case.
Oh.
No, I've all cased out.
Okay, we'll do this last one and then we'll, it's getting near the end of the hour. So this is an MRCP. What do you guys think about this MRCP? Oh wait, am I recording? Yes.
PSC.
Is this normal?
Abnormal. There's stricturing kind of in the central ducts. Has the patient had any like liver disease prior transplant?
Nope. No prior transplant, no history of liver disease. You say stricturing and you say centrally. I agree, there's stricturing centrally, but there's also like beading. So normally you should not see ducts all the way to the periphery. Like normally the MRCP really should only see the central ducts. So when you see them all the way out to the periphery like this and kind of like coming and going, like it disappears, it comes back. That is like the kind of classic beading of primary sclerosing cholangitis. So that was brought up in this case. And I will show you some more images. So they had this cute little finding here, which I'll show you. What do you guys think about the central area? Show you on the venous.
Does it drop out on?
Yeah, exactly. So
okay.
It has vessels going through it. So that's kind of like a really nice appearance for focal fat. And other things that can do that are like breast cancer, mets, lymphoma, but we go to the in and outs and we can exclude that it's anything like that. And I'll just show you, this is the in and outs. So the liver has fat in it, but there's more focal fat deposition in that area there. So going back to my venous phase, so that we're just gonna ignore that. We just got some focal fat there. And then you can now see the beaded ducts. So you see these peripheral ducts are dilated, but then as we get centrally, they just disappear. We don't see a mass there. So we're worried, you know, is this sclerosing cholangitis? And there is another finding in this exam that.
I mean, are you pointing towards the pancreas that it looks too smooth?
Yeah. Yeah, so what do you think?
IgG4.
Yes, exactly. So you can see that, sorry, this was a sausagey pancreas. We've lost the normal lobulated appearance. We have sclerosing cholangitis, and then they checked their serum, and you know, the sometimes in IgG4 you can also get beating of the duct. In this case, it just looked just completely like sausagey and featureless. So putting these together, this was IgG4. They tested the serum IgG4 as elevated. So it will be elevated in 2/3 of patients with IgG4. And of patients who present with the sclerosing cholangitis, about 95% will have a pancreatic abnormality as well. So if you see both of those together, definitely bring up IgG4.
Do you have to see both?
No, but it's, so if you have pancreas, it's less common to have biliary disease. Like pancreas is the most common in the abdomen. But if you have the sclerosing cholangitis, it is highly associated. Like usually you also see abnormality of the pancreas. Does that make sense?
Yeah.
So the differential though, if you see sclerosing cholangitis, it could be PSC, usually
Right,
younger male patients. It could be HIV sclerosing cholangitis. You can see that with, I think I showed a case a few weeks ago of that. And it could be IgG4. So if the pancreas is also abnormal, then you would definitely lean towards IgG4.
Yeah, if it's a new diagnosis, I add it anyways, even if the pancreas is normal, because it's so easy to rule out with IgG4, like serum.
Yeah, that's a good thought. But I will say, I think it literally is 92 to 95% will have something wrong with the pancreas too. So yeah, just a cute case.
Great case.
And, yeah, initially it was like, you know, they were kind of leaning towards like, is there a cholangio? Is there something, you know, here, like you can even see they were bringing this up, like why the ducts, but really a cholangio shouldn't cause bleeding of the ducts. So that's the clue. Okay.
And IgG4 of the like hepatobiliary, it can look just like PSC, but it can also have like, it can look like cholangio too, right? Like the.
Yes, there can be a mass forming type, and that is frequently misdiagnosed as cholangio.
There's a lot of different manifestations of IgG4 in the hepatobiliary region.
Yep. Okay. I think we're at the hour. So I'll see you guys later. Bye.
Thanks, everyone.